Welcome everyone. Today we'll see about colorectal injuries. Colorectal injuries has common following penetrating trauma, and it's the most common injured organ following posterior stab wound. And colon is the third most common injured organ following anterior abdominal stab wounds. So when we see the mechanism of the injury, right colon most common in blunt trauma, transverse colon in gunshot wound, and left colon most common injured after the stab wound. And when you see the diagnosis of colorectal injuries, usually the diagnosis of colorectal injuries made after laparotomy, and CT with IV contrast is indicated if non-operative management is considered, and fast DPL and laparotomy has little value or no role in the diagnosis. When we see the principle of operative management, we'll have approaches and options. We do have two approaches and options, three options of management. When we see the approaches, one is the damage control surgery. So damage control surgery is indicated if the four criteria are fulfilled: pH, intraoperative temperature, blood requirement, and total intraoperative fluid requirements. When you see the components of damage control surgery, it has three components, including resuscitative surgery, correction of lethal trials, and definitive managements with laparotomy. So resuscitative surgery considered has this is temporary abdominal closure after securing the blood pressure and decreasing the peritoneal contamination. So when you see definitive treatment of injuries, usually depends on 5 factors: mechanism of injury, delay between the injury and the surgery, overall condition of the patient, degree of peritoneal contamination, and the condition of the colon. Those are the 3 factors that usually have contraindicated as to primary repair. So if there is greater than 2 organ injuries, mesenteric vascular injuries, and extensive fecal contamination, we have to do resection anastomosis and colostomy or colostomy. So this is a grading system for colorectal injuries. There's 5 grading for colonic injury and 5 grading for rectal injuries. So if there is devascularization, it is considered as grade 5. When you see the management based on the grade, so if there is non-destructive colonic injuries, that means involving less than 50% of the bowel without devascularization, so primary repair should be done unless contraindicated. And if it is destructive injuries involving greater than 50% of the bowel or circumference and with devascularization, so resection and anastomosis or colostomy should be based on the indications and contraindications. So we'll see on the table, you can see that those are the factors that usually increase the risk of leak, and so indicated as to do colostomy. So those are injury factors, patient factors, and the others the mechanism of injury factors. From this, mesenteric vascular damage, shock upon presentation, hemorrhage greater than 1000 ml and greater than 2 organ injuries, especially kidney, and the interval between the operation and the presentation if it is greater than 6 hours. So we have to do diversion colostomy, resection, and anastomosis. So this is the algorithm based on the management of the colonic injury based on the grade system. So if it's grade 1 and grade 2, we can refresh and can repair. In grade 3, usually primary repair and resection anastomosis can be done. And grade 4, we can do colostomy or resection anastomosis based on the above factors mentioned. In grade 5, treat with colectomy and colostomy. We have to do colectomy and colostomy. So it's totally different based on the mechanism of injury, especially if it is high bullet injury, you have to do resection anastomosis or colostomy because there will be thermal injury that will increase the risk of leak. When you come to management of rectal injuries, it depends on whether it is intraperitoneal or extraperitoneal injuries. So intraperitoneal injuries can be managed, should be managed like colonic injury. Extraperitoneal injury, if it is small, clean, rectal injuries in a stable patient, we can do primary repair and plus or minus diversion colostomy. If there is high energy injury, extraperitoneal high energy injury in the proximal bowel, in the proximal rectum, so with significant contamination, we have to do primary repair as much as possible plus fecal diversion or diversion colostomy. If it involves the sphincter mechanism with significant bleeding, APR, abdominal perineal resection can be considered as a management option in extensive anorectal injuries involving the sphincter mechanism and with associated significant bleeding. The other controversial issues are the use of distal washout and pre-sacral drain. So most of the literature usually didn't recommend use of pre-sacral drain and distal rectal washout, but some literatures usually recommend it because distal rectal washout will decrease the risk of pelvic sepsis, and also pre-sacral drain will decrease the risk of pelvic sepsis. So in our setup, especially in developing countries, it's recommended to do pre-sacral drain, distal rectal washout. When it comes to antibiotic prophylaxis, we have to give at least 24 hours of prophylaxis because it has effective, at least effective as prophylaxis extending to 3 to 5 days. So we can give 24 hours or 3 to 5 days of antibiotics after management of penetrating rectal injuries. So when it comes to the timing of ostomy closure or colostomy closure, there will be a debate, but the traditional view is usually minimum of 3 months should be wait until colostomy is reversal, and we have to do contrast study to see whether the rectum is patent or not. But the recent study suggests we can do this within 2 weeks of the surgery.